how I was taught to address sacral mechanics are the four kingpins that contribute to the sacrum wanting to maneuver on an oblique axis versus a horizontal axis, were the multifidi, the piriformis, the QL, and the psoas.
When is the psoas not the psoas? When it's the ureter. And when is the QL not the QL? When it's the kidney and the kidney fat pad.
The imaging just gives you information, and sometimes it's good information and sometimes it's scary information, and you have to pull everything together at the same time.
Neck and thoracic posture is established, as far as I'm concerned, in the pelvis.
I know you'll give me the neuro angle right out of the gate, and my fascia people will give me the fascia angle, and sometimes it's treating all of it, and that's why having multiple machines is good.
The trick is when with scar tissue is to work behind the frequencies.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about, or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
This week was fun.
Good.
How is your week at Dr. Reynolds' office? I'm so excited to hear.
Yeah, it's kind of grown now to 2 days a week. It got very busy very fast. I'm becoming an expert in shoulders and knees because he seems to be an expert in shoulders and knees. Therefore, I'm seeing a lot of shoulders, knees. Actually, that's not true. And SI sprains, strains, sacral torsions, because that seems to be the kind of the missing component to a lot of people. They can assess the hip, they can assess the low back, but when it comes to sacral mechanics, I think it can stump a lot of people because it gets thrown into the same bucket as weak glutes.
Oh, yeah. Hang on one second. How'd you, oh, there you went. And the sacral torsion, nobody looks at the psoas the way we do. And so my pelvis is torqued. Yeah, because your psoas is tight on both sides, but on one side more than the other. And then it does this. And so let me work on your ureter. Okay. Just tell everybody I'm working on your psoas, but this is how that goes.
And how I was taught to address sacral mechanics are the four kingpins that contribute to the sacrum wanting to maneuver on an oblique axis versus a horizontal axis, were the multifidi, the piriformis, the QL, and the psoas. The multifidi and the piriformis are the ones that lock it up on that oblique axis, and then the psoas and the QL kind of come in as reinforcers. And so you have to treat all four of those muscles bilaterally for that sacrum to feel safe, to go back to that beautiful kind of horizontal position.
Multifidi and the piriformis
typically will anchor that oblique axis.
Right.
It piriformis on the inferior axis, multifidi on the superior axis, and then psoas and the QL bind the two.
So the multifidi that attach from the transverse processes and the spinous process of L4 and L5, those little teeny muscles?
Little teeny muscles, they do a whole lot.
And then there's the Dura, which is only something we talk about, which is, thanks to Eduardo, the Dura attaches to the sacrum and the coccyx just inboard from the iliums. And if the Dura is tight, then the pelvis goes like that or like that. And
anterior, posterior, for those of you who are listening without the visual cues of the thumbs going.
There we go.
Anterior, posterior.
And then we treat scarring in the Dura, and all of a sudden the pelvis is different. It's scarring in the ureter, and all of a sudden the psoas is different, and then the scarring in the kidney and the kidney fat pad, and then the QLs are different. I'm talking about this because I get to do it yesterday. And this kid was he said, I'm just really stiff. My low back is so stiff. And I went, I have 20 minutes until my next patient. Here, lay down. And but then and pretty soon it was 3:15 and I was 15 minutes over time, but all of a sudden he can move his shoulders and he said, and I can take a deep breath and I can move. And yeah.
The everything is attached to everything is a thing. So we have to use our biomechanics and we have to use our reflexes and we have to use pinwheel and sensory exams and all of that to help give us some information. But I think what clinicians, especially older clinicians, we get caught up in the formula that we used to use, and that has to adapt and pivot when we use FSM because you're able to cast a wider net.
And you have a toolbox that lets you do that. You can't even think about adhesions in the dura or a tight psoas that you can release in, I've got 20 minutes.
Right.
Who does that except us?
And it's funny with all these new patients that I'm seeing, when I go through my assessment and I talk about some of the muscles, or they'll ask, what are some of the muscles that we're going to treat? And I say things like multifidi and piriformis and psoas, and their faces scrunch up. And I'm like, what's the problem? My PT has treated those and my massage therapist has treated those, and it really hurts. And I said, oh, I get it. It used to hurt, but I have a tool that's going to allow me to treat these muscles, and I'll be able to get in and get out, and you might even fall asleep. Who can say that they've ever treated someone psoas and that patient was almost asleep on the table? Nobody, right? Those muscles are exquisitely tender and deep for a reason. And I wouldn't even attempt to treat a sacral torsion anymore without FSM. Hands down, full stop, end of sentence, would try it. Because to your point, it's not just treating those muscles. It's not just taking an elbow and going through someone's piriformis. It's creating an environment that those superficial muscles and the fascia allow you to sink in to treat those muscles, if you even need to treat those muscles.
Yeah. It only hurts because you're pressing on the ureter, and the ureter is innervated as a pain nerve by the vagus, and it's exquisitely painful because it goes directly to the brain. And so when is the psoas not the psoas? When it's the ureter. And when is the QL not the QL? When it's the kidney and the kidney fat pad. And it's
Right.
like, huh? Okay. And that's why it was painful before. And that's why it didn't work before. It's like,
Right.
yeah, my QLs are always tight. And then, through that we had a practicum last weekend, and I got the best compliment I think I've ever had, and it's from an established 50-something-year-old pain specialist. And he sat there as we went through the practicum slides, and you could tell that he had not finished the core.
Right.
And he said, as we went through the practicum, just the practicum, he said, this is the best musculoskeletal diagnostic class I've ever seen or heard of. And it's just not that hard. And we had, for the first time ever, do scarring the kidney, sclerosis in the fat pad, and then just out of habit, you go up 2 or 3 ribs and you try to rock those, and they're rock. They just don't move. Do you ever have pneumonia? Yeah. We had 3 patients with pneumonia and ran into all 3 of them and changed their pulmonary excursion by 20%.
Wow.
Just because we did scarring in the pleura and then scarring in the intercostal nerves. So you just torture them a little bit with the intercostal nerves and then scarring in the pleura and rock the ribs and then have them take a deep breath. And it's like, I haven't Yeah.
And those inhalations sometimes need guidance, whether it's hands on the rib cage, telling them, fill out your rib cage into my hands, both laterally and AP, right? Because we breathe with all different ranges of our ribs. We used to say so much of it was bucket handle and pump handle, and the new like kind of MSK ideas are that it's more of a global rotation that happens, right? More of a ball that lifts and deflates. And that's all the research that we're doing with fascia right now. So yeah, so there's many different cues that you can give patients who, if think about inhalation and exhalation just like any other movement, like flexion extension in the elbow. If somebody has been restricted for a long time, they're not going to believe the breath that they can take, and they may need some guidance on how much air they can actually breathe in and how they can also deflate and compress, right? Those of us who are runners, I know it's hard to believe, but we actually need to be more efficient at exhaling than we need to be at inhaling when we're running. It's about getting out the CO2. So I think we do a lot of work in the clinic with taking a deep breath and what that inhalation looks like, but cueing and exhalation can be just as effective, if not more effective.
Yeah, it takes different muscles. And there's a certain amount of 40 and 89 quieting the fear of moving my chest, because the hippocampus thinks that my intercostal nerves are still scarred, that my pleura is still scarred, and the tools we have that allow movement to change so quickly involve the ability to manipulate the central nervous system.
Right.
So the patient has this look on their face like, what? Who? Huh? Let me just run 81 and 92, which is increased secretions in the sensory motor cortex, so that your brain catches up with where your body is now. So move your shoulder, take a breath, whatever we changed, and then quiet the midbrain so it doesn't get upset, and then increase secretions in the cerebellum to coordinate the movement. And this pain specialist watched that all of Saturday. He didn't treat anybody. He didn't get treated until I worked on his neck on Sunday afternoon, because he hadn't been treated. He'd been watching. I said, yeah, you don't get to just watch. You get to experience this. And his one wish was to sit up straight. He said, I always slump. That's how my posture's been my whole life. Okay. So I worked on his neck, and it was like a brick. No trauma, just bad posture. Okay, crabby facets. So got his neck to move, used the little activator on the upper facets, and made him sit down, perch on his ischial tuberosities, and stick his belly out. And then all of a sudden, now he'd been trying to do the figure out where your upper thoracic muscles are, the thoracic paraspinals, that exercise. And that didn't go particularly well, but he was trying. And somehow he must have found those muscles, because when I sat him in a chair and put my hand in the middle of his low back and said, stick your belly out. And then all of a sudden he's like this. I'm not slouching. And then he's sitting buying something from Kevin, and I come by and shove my hand in his low back, and I said, this was the one thing you asked me 2 days ago. Sit. Then he stood up, and he was slouching, and I came by and stuck my hand in his low back. Neck and thoracic posture is established, as far as I'm concerned, in the pelvis. It's just all you do is that. And they said, and then keep your nose horizontal. Because as soon as he went like this, his head went up. I was like, no, do that. Oh, okay. That was really fun.
Yeah, the little cues that we have to make, I think. So here's what I want to talk about too, is when we get really good at fixing somebody for a few treatments, and I'll say taking their pain from an 8 out of 10 down to a 3 out of 10. And then after about a month or so, it goes back up. We typically, FSM practitioners, and even those who email me, the story is not just it doesn't just happen to me, it happens to a lot of people. And so instead of taking it personally and hitting the panic button, the first thing I typically say is, how much did their activity level increase in that first little while? And when you take somebody who is in a lot of pain down, especially if they were active or are an active person, they tend to push it very quickly. And I think that's probably the hardest thing about patient education that I've really had to learn the hard way to stress, is that this pain reduction that you're feeling is going to stay down so long as you don't act crazy and do more at the gym, do more walking, and it's going to be hard because you feel good. So you want to be mobile and you want to test it and you want to be strong. But there are still firing patterns that need to take place. There is still strength that needs to develop in muscles that have been offline for years sometimes.
Yeah.
My first piece of advice to the clinicians that are listening is go back, do what you did before that got them out of pain, and talk to your patients about still having to respect the healing process and the recovery process.
Yeah, exactly. I got a email from a patient in New York. The patient had Ehlers-Danlos, and I wrote a 4-hour or 5-hour, an hour of 40 and 10, an hour of 124 and 77 to normalize the Ehlers-Danlos and then turn on the vagus. So it took about 4 or 5 hours. And then I got an email from mom who said, my daughter ran that program and she woke up all stiff and sore. And it's, yeah, her range of motion is completely different. We usually run it the first time when the patient's awake. I can't imagine doing it when they're asleep and they wake up and they're a different person.
Right.
That would hurt. So
Yeah.
you need to do it again while she's awake and she can move the muscles, because they wake up and their arm is completely different. They don't know. It took us 30 minutes to teach this one hypermobile. We don't get the vascular serious kinds of EDS, but a hypermobile EDS, 9 out of 9 Baton points, -10, -15 degrees at the elbows and knees. And she finished treatment and we had to teach her to walk again. And it was 30 minutes of toe heel, toe heel, toe heel. And that was after all of the central nervous system stuff.
Right.
It was physically integrating so that she could get used to the tendons that are now normal instead of hypermobile. And in this class, we had 15. Is that what we had over the weekend? I think it was 15, 12, 15. Huh?
10.
No, because we had 4 tables of 3. That's at least 12. And so let's say we had 12. Out of the 12, 20% of 12 is what? 2.5. And we had 3 Ehlers-Danlos, 3 hypermobile, and 4 vestibular injuries.
Right.
It's 20% in every class.
Why do you think that is?
I think that's probably the percentage that is in the average patient population that we all see, because vestibular patients get injured because they don't know where they are. They tend to be anxious and don't know why. They have all these symptoms and don't understand them. Disequilibrium tends to make people anxious. they have all the sequelae of that condition, and nobody seems to diagnose it or know about it anymore. Sorry, somebody just asked a really long question. And then 20% of hypermobile patients, when you look at your patient population, maybe not yours, because hypermobile athletes, unless they're, I have my suspicions about some track and field pole vaulters. There's no way that is not a normal thing to do to your body when you look at how high they go and how much they bend. Gymnasts. So in the general population, the clues that we talk about at the advanced, in that first portion of the advanced, was I did gymnastics in grammar school and high school. I did ballet. I always sprained my ankles. My knees hurt. So the patient that I treated for hypermobility came in and her knees were killing her. And you feel her knees, and now the quadriceps tendon is the normal length, and her patella is jammed up against the femur, jammed against the bursa and the cartilage. And it's the old-fashioned diagnosis is chondromalacia patella, but that's a BS diagnosis. And it's just because now your quadriceps is acting normally. And all we have to do is treat torn or broken in the tendon to get it back where it belongs, inflammation in the cartilage, and inflammation in the patellar bursa. And so that was unattended. And then her neck was unattended. And the vestibular rescue, just 40 and 44, running for the full hour that it took me to program their custom care. And it was like, okay, it's
Yeah, what you would say not that hard. The chondromalacia patella is one of those kind of eye roll moments that I see, and I see a ton of it now, the San Jose Clinic. Again, when we think about what's going on, yeah, there's some inflammation, but the inflammation is secondary to that torn and broken pattern that is there on the tendon. And why is that torn and broken on the tendon? Because there's a dysfunction usually higher up in the quadriceps. Right? The patella is like a lever, right? It's not the patella that's truly moving. It's glidey. It's being pulled up and down. And so the trauma that happens on the inside of the kneecap doesn't happen from outer space. It happens from usually an imbalance with the quads. And yes, we have to address that inflammation that's there. But typically when you treat the torn and broken, the 124, the trauma on the periosteum, the inflammation kind of takes care of itself. It's just like treating bursitis, right? It's thinking about why is the bursa angry? Running around the bursa. What's the bursa's job?
in this particular case, it was easy because both of her knees were minus 15. And now the whole hip, knee, ankle mechanic changed because she said, I can't stand that way anymore. When you stand that way with your knees back at minus 15, your patella is no place near the femur or the cartilage or the bursa. It's all hanging out here in space because the knee is locked back that way.
Totally.
Now you change the tone in the tendon so the knee is in neutral where it belongs, and all of a sudden the patella is in contact. And I didn't even apologize. It said, oh, that's a good sign. It really hurt. It was like it was horrible. And it's okay, yeah. And part of that was because she went down on her opiate medication too fast. So we talked about how to do that more easily.
We have a couple questions that are coming in. Sounds like there's a lot of stuff here. So we have one question. I think that was the long one that you saw.
Yeah. You want me to read it?
Yeah, so it's just asking to talk in detail about what you wrote in the book about a football player, what you called stripping, quote, stripping the scar tissue, quote, bloodless surgery. I use 13 and 58 to address scarring, but I'm wondering if there are manual techniques like gua sha, or is it just running 13 on the correct tissues? For instance, 3-month-old hematoma scar that does not change with FSM. You stop bleeding in all tissues, 284 in all tissues, scar frequencies on fascia, nerve, muscle, tendon, adipose, bone, periosteum. Skin is red, 3-inch hard lump under it. Is there something I'm missing? Don't understand about moving scar tissue. Ooh, I have so much to chime in on, but I'll let you go first.
I will let you chime away, but the thing with scar tissue is mobilization and being very specific with what tissue your fingers are on. So I have this funky finger here, and I went to OT today with a precision carer, and she had an ultrasound. So we looked at the tissue because we can't figure out what this nodule is made of. It feels like connective tissue, and she was into it. We used, is Graston those metal things that I hate?
Yeah, gua sha, Graston, there's scraping. Yeah.
And the other ones, the plastic ones, either way, first time and on my hand, and identified the tissue we were on by how it felt. I said, yeah, that's nerve. And the nerve is tangled up here, and this is connective tissue. And it ended up that the metacarpals here are not moving properly because the carpals are not moving, or vice versa. So you always need to, the short version, Sherry, is you always need to use your hands. And I started with the 58s with Terrell, and I didn't do the manual work because I didn't have the hand strength. Brian needed to do it because when you're working on a football player, their fascia and connective tissue is so strong that there's no way I could have done Terrell in, what did we work on? That first day we did 5 hours on Wednesday before the Super Bowl. And we started at his knees and we stripped nerve and fascia and connective tissue all the way down to his foot and between his toes. And the trick is with scar tissue is to work behind the frequencies. So the frequencies make the scar tissue soften by 1.5 millimeters, maybe 2. And then you take that softening, take it up and move it and break the bonds that hold the scar tissue together, and then go on to the next sticky spot and the next one and the next one. The 3-inch hard lump, the skin in the area is red, and there's a 3-inch hard lump under it. I would try uric acid and 217. I don't know how old the patient is. 284 maybe. But the other possibility is if it's just under the skin, sclerosis in the adipose. It was easy with Terrell because you don't have to worry about adipose on somebody that has 6% body fat. They're just not a thing. So that would be my guess. And I have somebody that wants me to do a phone consult. And I don't know about you, but it's just impossible. You can't do a phone consult without getting your hands on somebody.
No, I did one yesterday and it was very frustrating because they kept talking about things. I'm like, I need to see and feel. The descriptions were great, but just going back to this one question. So yeah, 58s, I don't typically ever use them. I go to them when nothing else works in the viscera. And even then I don't really have much faith in them, to be honest. Teen absolutely needs to be mobilized. Even putting a limb on a passive stretch while you're doing manual therapy can really help expedite the results with 13. We talk about it dissolves the bonds in the adhesions. The slide I think both of us use when we are doing the courses is the old-fashioned phone cord. And so just gives you a visual of what bonds could look like in that cord. And as you kind of pull that cord apart, whether it's on a passive stretch, even a PNF, which we do in the rehab course, manually breaking up those bonds. So 13, I don't really even program 13 on a custom care for home use unless I'm showing them how to mobilize while 13 is running with a passive stretch, with a PNF, with assisted stretching, something like that. So maybe that's what it needs to be mobilized a little bit more. Another interesting study, and you talked about like adipose isn't a thing with athletes that are so lean. However, there is intramuscular adipose tissue. There's some really neat studies on it right now. So sometimes sclerosis in the adipose I do drive-bys on it all the time just to think if it's 13's not doing it with the connective tissue or fascia, maybe it's that intramuscular adipose tissue. We see that a ton in the gastroc, which has the highest amount of this intramuscular adipose tissue. It's kind of crazy, but that's there. Yeah, that was my 2 cents. All right, let's move over to Q&A. Somebody says, I was looking at the anti-aging protocol in the mode bank and noticed it includes 160 and 102, which runs for 60 minutes. What's the story behind that? I don't know what 160, 102 is off the top of my head.
On the anti-aging protocol? I'll check the mode bank. That looks like a typo. 160 is malignant virus, 102 is the pineal gland. It would be an anti-aging protocol, but for 60 minutes? That's strange.
I've never used that one.
It makes sense that I'm having conversations with practitioner that attended, he's out on the thin edge of the branch, or he's on the cutting edge of medicine, depending on how you look at it. And he's, not only him, but a number of practitioners have talked about calcifications and minerals, and mostly calcifications of the pineal gland as interfering with melatonin production. And melatonin is an anti-aging drug. 60 minutes sounds like a typo. That because the skin anti-aging protocol only runs 60 minutes total. And I know it's mostly for skin and connective tissue and torn or broken and connective tissue and increasing secretions in the fascia. So I'm wondering where that came from. I'll go look in my mode bank. Hi, Leaf. So this calcification and mineral deposits, and there was one of the metals, I think maybe aluminum, in the pineal gland. That was interesting. There's that one. Right and left burst Baker cyst that flared the RA. Okay, whatever she did that burst the Baker cyst was also hard on her joints, and that flared the RA. There's been edema around the ankles and knees. Yeah. Aside from running lymphedema and 14 at the 50 run around the knees and nerves and doing some lymphatic drainage, still having some inability to fully extend the right knee. Had a fear of standing, but we've addressed that. Flexed elbows that do not extend fully or fully flexed. Swan neck deformity in the fingers. Scarring minerals. That improved a little bit, not quite as rigid. Have either of you been able to help restore functional movement with these degree of RA? I'll give this one to you.
So right and left burst Baker cysts. So Baker cysts are in the knees. So I would have a question about that. Did she have bilateral Baker cysts and both of them burst? Interesting. So RA, as we know, autoimmune. So there's that sort of underlying right there, right? So I would hope that you're treating the vagus nerve, because anything that's autoimmune, I go back to that all the time. And then, so I think you're on the right track for running the edema and the scarring, but I would be chasing the vagus nerve for sure, because RA is, I just can't get away from anything that's autoimmune. So we need to make sure the vagal tone protocols are running. Let's see. That's my kind of limitations with RA. I always go back to treating the vagus. And then the patients that I've had really successful work with treating RA, you do have to treat the muscles. So I think you are on the right track, especially with 13, 51, 91. I also like to use 20 pain and pressure. 30 is irritation, 50 is congestion. So I do love those frequencies also with the tissues. And I think you're on the right track doing lymphatic drainage. I've been using, so as we know, 13 is lymph. And then there's also lymph glands, which I forget the frequency right now, but I've been using that in conjunction with manual therapy. So that could be something to try, Suzanne.
And the other thing that is almost counterintuitive in rheumatoid arthritis is the inflammation from the autoimmune disease makes the tissues gummy. So try 124 and the connective tissue. And then remember that the immune system attacks the synovial membrane.
Yeah.
So that's 386.
Right.
So it's inflammation in the synovium,
Yeah.
386. And then if you think about how do you get fingers that are shaped like that? If the cartilage and the synovium was normal, you couldn't. So you'd have to do inflammation, torn and broken in the cartilage, and then treat the connective tissue, the joint capsule and connective tissue that are attached to it that make it operate.
Yeah, the Synovium 386 has also been a huge frequency that I've been just adoring in the last year or so, especially working with an orthopedic surgeon, and I'm getting these wonderful reports and I get to geek out on MRIs. And when I'm hearing these words, it's the capsule, it's the Synovium. Those are coming to my forebrain a little bit more with treatment. So you could try congestion in the synovium. I've been having a lot of results with that. So 50 can be great. So it's not always inflammation. Sometimes you can think of those other words that create that congestion, pressure, that sort of stuff. Thank you. 63 is lymph glands. Thank you, yes. Suzanne and Linda.
And with rheumatoid arthritis, especially if it's an older RA patient, you can use 54 for necrosis in the synovium. So by the time they get swan neck deformities, the synovium is, I think the technical medical term is trashed, and it's just not holding the joint together.
Right.
The joints aren't swollen particularly, they're deformed because of the inflammation and the tendons not holding the joint in the proper position or using the joint properly.
Suzanne wrote that she had done 124 in all tissues with 386 as well. So that's great, 124, but try pain and pressure, try 20, try 50 and see if you get any results with that. So pain and pressure and congestion. And then let us know next week if you could. Yeah, and 54. So those are our two nuggets. And then just the two Baker cysts. So the chiro had burst, the right one and the left one burst on its own, both about 2 years ago. Okay, because like that seemed interesting to have two burst Baker cysts. Okay, another question. When you have someone who has had a collapsed lung a couple times, they get blebs on their lungs that can rupture. I think it would probably be dangerous to run anything to reduce scarring in the lungs. Do you concur? I'll give that one to you. I don't treat lungs.
It's the actions. When you think about how the lungs are built, there's no point in reducing scarring, because if you think of the tissue as like a sponge, so our cadaver had pneumonia on one lung, and that's what killed him. and no pneumonia on the other lung. And the part of the lung that was normal was like a sponge, like an ocean sponge. It was squishy, and there were bubbles in it. If you have someone who has scarring in those little bubbles, we only have a frequency. We do have a frequency for the alveoli that's experimental, but if you run scarring in the lung or scarring even in the alveoli, what are you doing? You're going, if you can relieve the scarring, then you can, if you're successful, and that's a big if, you're going to pull apart two little bubbles, but they're still going to be stuck to something. I've just never done it. I've never been successful. Even in COPD, we run congestion, we run inflammation. They always feel better. We'll run 51. It's just not something I have a lot of mileage with.
Alf wrote, typically a collapsed lung does not have a hole in it. It is from air outside the lung pressing on it.
Yeah.
Very good.
And you can have air or blood. You can have a hemothorax or a pneumothorax. And basically what they do is put a tube in and suck the air out, or put a needle in and suck the blood out. And then as the needle or the tube comes out, they try and close the hole. And that's what the suction is for. I have a story I have to tell.
Do it.
I had a patient that sent his cervical MRI first, and he had an appointment and he made it 4 months ago. And I looked at his MRI and went, he shouldn't come. That's a surgical neck. I'm just going to give him some bad news and send him home. So he came in and we talked about his imaging and his history of trauma and what he did. And he only had one accident, and he was an IT guy, a major in the Air Force. So he did a lot of PT and a lot of the things you have to do to pass your physical qualifying exams to be a major in the Air Force. I went, okay. And there's this disc that's impacting the thecal sac, but the view that we saw, it's making a dent in the spinal cord. So I expected tight legs, I expected hyperactive patellar reflexes, hyperpositive Minsky, and none of it. He had +1, +2 knee reflexes, +1 or 2 patellar reflexes, no clonus. He did have tight legs, but I looked at him and I said, your MRI is surgical, but you are not. Your physical exam is not surgical. So forget what I said earlier. You have to examine the patient, not the imaging. And you have to treat the patient, not the imaging. So I thought that was kind of fun.
Yeah, again, seeing that a ton in the clinic that I get to participate in, where we're seeing MRIs and images that don't match the patient complaint or how they present. And we'll have an octogenarian that is a marathon runner that has no cartilage in their knees and is pain-free and is continuing to run. And then we have a 30-year-old who's in a ton of pain and has big fluffy knees. And so you do have to treat the patient, and the imaging just gives you information. And sometimes it's good information and sometimes it's scary information, and you have to pull everything together at the same time. Susanna had just written in, can you speak a little bit more about treating 238? This has been highly effective for clients not responding to meniscus, ligament, tendon, connective tissue, fascia, and capsule around the hips and knees. I would totally agree with that. Most recent client has had a previous hip injury that eventually healed, but was reactivated 2 years later hiking to Alpine Lake. Glute med was so contracted, it was unable to side lift leg or abduct. She did a neural manipulation of the spinal nerve and the muscle relax. But before this, she had tried 20 and 30 So pain, pressure, and irritation on the synovium and periosteum. And that took pain down from a 6 to a 2, yay, in 30 to 40 minutes. Can you talk more about how this plan is generated and why this works? That's a great question. So I feel, and that's why I have put in 20, 30, 50 in the sports advanced courses, because they were like my investigational frequencies. And so the pain, the pressure, and the more books that I personally read from the osteopaths in the 20s and the 30s use these words repeatedly. So Dr. Codman's book on the shoulder talks all the time about the congestion that he sees in the capsule and in the synovium. I don't know what he was referring to, but I have to think it was worth listening to because it works. So pain and pressure, I also use that as more of the emotional frequency. So I will use it when I hear I have so much pain and pressure in my knee. I also use it when I hear athletes talking about the pressure they have to return back to the game. So 20 has a very big place in my practice. 30 is irritation. Again, Dr. Codman uses that word all the time in the shoulder, that the labrum was irritated, that the capsule is irritated. And he's talking about these frequencies when these patients are open. This is in an operative kind of setting, and he talks about the words irritation. So I don't know exactly how those frequencies work in the periosteum or the synovium. Maybe you know more about the mechanism of action with that. I don't, but I know that they use those phrases all the time. And that to me was worth listening to.
Yeah. The only place I stay away from the bone marrow is in blood dyscrasias, where the red blood cells or the platelets are too high or too low. It's just like I don't go there.
Sorry, yeah. So it's not just the synovium. Sorry, 238 bone marrow. Sorry,
Yeah, bone marrow.
that was my
And
fault.
I got a surprise when my massage therapist was working on my TFL after my hip surgery, and nothing was working. And you know how the TFL is painful. And all of a sudden it turned to pudding. And I said, "What are you running?" She said, "Scarring in the bone marrow." Why? Why would you run that? And she said, "I just had little bird on my shoulder started talking to me about the fact that you have this pin in the bone marrow, and it's scarred in there, and so the body is going to do its best to keep the bone from moving, because that pin has to stay where it is, scarred to the bone marrow."
Right.
And that's absolutely brilliant.
Again, seeing in the clinic that we're at, bone marrow edema, I think I'm going to give this one credit to Ben Catholi, who talked about 14 and 238. And I know with my own daughter, when she dislocated her shoulder for the first time, there came to a point where FSM wasn't working. We always know that it works, especially with kids that have the buy-in, that were raised on frequencies, that go to the custom care before they go to the first aid kit or grab an Advil. And she said, "Mom, it's not working anymore." And when I re-listened to the orthopedic surgeon who made a great video going through the structures of her shoulder, said the only thing I really see right now is this bone marrow edema. And I texted Ben Catholi, and you should try 14 and 238. It works really well. And I had not used it up until that point. So it's blinded. I said to her, "I'm going to try this and see what it feels like." Nothing had worked. And she's, "Oh, whatever you're running, it feels so good." So sometimes I'll just go with this anecdotal evidence of, okay, if it worked for this kid, it might work for another. And I've been using it quite often. And
So
I just
14,
14, 238.
is it 14 is edema from the West Indies frequencies, right?
Correct. Yeah.
Interesting.
Yeah. So
Well, and the patient from last week, where he had the screws that were pulling out of the spinal column, there's bone marrow in each of the spinal vertebra.
right.
And so we treated those for metallic toxin in the bone marrow, and
Right.
that worked out really well. It obviously took his pain down. I'm not sure which one of everything I did worked, but that was a fairly good guess.
Sometimes I think when one frequency works, then I think right away what happened before or after that. So if you think of that, especially the A channel. So if scarring worked, why did it work? And what could I still use to keep it working? So if something had scarred, there was usually some sort of tearing that happened before the scarring. And if something tore, there was probably some sort of trauma. So sometimes you reverse engineer the scarring effect, right? And you have to kind of go back in and finish the job. It's if you're digging out a cavity, you can't just stop in one spot. You got to dig a little more, make sure you got everything out. So that's how I think of the scarring frequencies. And then also, Susanna, we're talking about your RA patients. A lot of the autoimmune patients do really well with vitality. When you give that work with the vagal tone and get that vagus doing what it needs to do, I always go in. Think of Dr. Roger Billica's work with putting in the good before you take out the bad, but really just bolstering the good. So a lot of vitality in those tissues for those autoimmune patients can do really well. Again, going back to this most recent case that you were talking about with the bone marrow. So running 14 and 238, you can go back after you treated bone marrow edema and run vitality on those superficial tissues sometimes too, can be really beneficial. That's sort of it for the Q&A, I think. I don't know. I just want to make sure we didn't miss anything. Susanna, you always have really good questions. Sometimes we have regular people who ask questions, and Susanna is one of our regulars, and she brings really thoughtful questions to us. So I want to just say a big thank you to her.
Thank you.
Yay.
Well, it means that, number one, you're using FSM, you're using it on complicated patients, and you're thinking through what's causing what to the point that you need to ask. And that's a clue. We have a brain trust. I'll text Kim, I'll text Ben, I'll text Dave, I'll text various people. I have this thing, and what do I do? If what I do doesn't work, then I need to find out what somebody else is doing or what somebody else thought of.
I think FSM is one of those things that we all come at it from a different angle sometimes, especially based on our backgrounds, based on our training, based on the patients that we're seeing. And it's really nice to have a study buddy or a group that you can collaborate thoughts on and say, have you tried treating it from this angle first or that angle? And when I text you, I know you'll give me the neuro angle right out of the gate, and my fascia people will give me the fascia angle. And sometimes it's treating all of it. And that's why having multiple machines is good. So I'll think of, okay, I've got a custom care running on Carol's ideas, and I've got another custom care running on Ben Catholi's ideas, and then my ideas are somewhere in there. And I think that can be a great way of handling those really tough, kind of complex patients. So if there are no more questions, I might have to jump off a little early today because I have to run back and treat somebody. We have 3 minutes. I don't know if you have any announcements to make or if we have anything else to cover.
Let's see. We have the rehab course in Costa Rica in October.
Yay.
And it's still the rainy season, but it's sunny all day and then it rains at night. So that's fun. We're going to London for what's IPM stand for? Medicine, some Congress this week. And then,
personalized medicine.
So what is it?
Integrative personalized medicine.
Integrative personalized medicine. And then we have the seminar in London in November. And then we have Poland, an advanced anacor in September. So it's a busy month, busy year. It'll be fun.
It's the year of the fire horse, right? That's what somebody told me in yoga. So yeah,
Well, and
a lot of movement and activity in 2026.
I'm a fire dog.
There you go. So this is like your year.
I have a friend that's a fire dragon.
Oh.
And that fits. It's really interesting to look them up. There are surprises in them. And this is year of the fire horse. So all sorts of fire going on.
Literally, yeah, lots of movement. So those of you who do listen to the podcast or watch us on YouTube, if you have questions, it's never too late. You can always email us those questions and we'll try to address them when we are live, because that was one question I actually got was if I'm watching you after, how do I ask the question? So I believe there's probably, Kevin, I think there's a jot form or something that we get those questions to. you can email me directly at kim@fsmsports365.com, and I will bring it up and answer them live, because I think all those questions are, if somebody has it, then another person has it, and it's worth sharing.
Yep.
So
and the questions are the most fun because it makes us think too.
totally, yeah. And it puts us on the spot, which is what happens in the clinic. We get put on the spot and we have to think quick. And hopefully we have a couple machines, because sometimes that's what I need to think things through. So at least I know I have a few machines doing their job, and that buys me some time to troubleshoot or to think laterally.
Especially when, you know, these two are for sure working, then what is it I haven't thought of? That's what the third one's for.
Right.
Yeah.
Or at least, like I said, it buys you some time to phone a friend.
Yeah. You got
Yeah.
it.
All right.
Good
My
luck.
alarm is right about to go off. So we'll just sign off now, and we'll see
Sounds
everybody here
good.
next week. All right.
See you next week.
Not next week.
Not next week.
Oh, not us. We're going to be in London.
Okay.
So
I will be a TBD. We'll see if I can get somebody on here.
that'll be fun.
All right.
All right.
See ya.
See if Ben or Dave can come on. That'd be
Well,
fun.
I'll ask.
Oh, be good.
All right.
Judy. Talk to you later. Thanks for coming, everybody.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.